Welcome to the Brains and Needles podcast. Today we are going to talk about a symptom known as DRESS syndrome. Yes, DRESS syndrome. So what is it? If we go by we'll elaborate about the name, DRESS syndrome. Each word, like I'll say it, like DRESS goes from drugs, rash, eosinophilia, systemic symptoms. So in this, there is a hypersensitivity reaction, which usually occurs after taking a drug, and you'll see the symptoms in 2 to 6 weeks of taking the drug, from the time you have taken the drug. So when the patient takes it, the patient has fever, malaise, lymphadenopathy, and even facial edema, but which can be confused with the normal hypersensitivity reaction which occurs just after taking drug. But here it occurs after 2 to 6 weeks. So what happens when such kind of hypersensitivity reaction occurs? There will be increase in the lymphocytes, which are the T cells, then eosinophilia. There will be damage to the internal organs such as kidney, liver, lungs, and spleen, maybe, and many more internal organs, and many tissues will be affected due to this hypersensitivity reaction. So the patient comes with fever, malaise, lymphadenopathy, facial edema. There will be a kind of rash, morbifiliform rash, which will be present on the body. Like more than 50% of the body will have these rashes. These are, like, you'll see many red spots, like small spots, not like papule, but a reddish rash present all over the body just after taking the drugs. Like not immediately, but after 2 to 6 weeks after taking the drug. So let's dig deeper into the pathophysiology. But before that, let's see what kind of drugs cause it. So there are many drugs which can cause DRESS syndrome, but the common ones in the clinical practice which are seen are allopurinols, antipsychotic, antiepileptics, sulfamides, vancomycin, which can cause this kind of syndrome. So what basically happens? Now a drug is a prohaptin, so it needs to be metabolized or is metabolized to a haptogenic form. Okay, once it gets metabolized to a haptogenic form, it gets attached to a carrier protein, and then they form a complex of the haptogenic form of the drug and the carrier protein. Once they are formed, a complex is formed, these are immediately, like not immediately in this case, but after 2 to 6 weeks, are seen by the circulating B cells and the macrophages, which are antigen presenting cells. They present the antigen to the outside complexes, which is, like in this case, the drug. They get attached to this. Once they get attached, they move to the lymph node, in which they are exposed to the CD4 cells or the T cells, which have CD4 receptors. Herein, the CD4 cells or the T cells are converted from T helper cells to T helper cell 1 by the action of interleukin 12. Once these gets converted to T helper cell 1, these T helper cells are further differentiated by interleukin 12, and while this process is going on, the T helper cell 1 will give out interleukin 2, which will then cause activation of macrophages with the help of interferon gamma and tissue necrotic factor alpha, and also activate the T killer cells, which will eventually then cause tissue damage wherever in the body this reaction occurs. And another type of pathway in where the prohaptin is not metabolized to a haptogenic form, rather it directly comes into contact with the B cells, circulating B cells, and the macrophages, and again the same process happens. It goes to the lymph nodes, and then they get exposed to the T helper cells or the CD4 cells. The T helper cells get converted into T helper cell 1 with the help of interleukin 12, which then again differentiates the T helper cell 1 And on this process, the T helper cell 1 give out interleukin 2, which again fastens the process of activating macrophages and T killer cells, which eventually cause tissue damage. Another pathway by which this can occur is like, let's say a drug is taken and it is reversibly causing this reaction by presenting itself to the antigen presenting cell like the B cells and the macrophages. This time they get attached or get exposed to the receptors of T cell receptors. They get attached to T cell receptors. Again, the T cell receptors go to lymph nodes, and then T cell receptor in the lymph nodes converts T helper cells to T helper cells 1, T helper cells 1, activate macrophages and T killer cells, and eventually causes tissue damage or tissue inflammation. Also, in this process, there is reactivation of the virus which was dormant. So basically, as I explained, after the T helper 1 cells activates the macrophages and the T killer cells. After that, these macrophages and the T killer cells activate the cytokines such as interleukin 1, 6, tissue necrotin factor alpha, which can cause immune responses or can cause increase in the immune responses. So many of this virus are present in these immune cells which are dormant. So once the immune response is activated again, these cells or the virus present in these cells also gets activated and then further cause the tissue damage, or the infection comes back, such as human herpes virus 6, 7 or Epstein-Barr virus can get activated. And another pathway by which it gets activated is like in a B cell there can be dormant viruses, and then when this complex of this drug and carrier protein comes, they stimulate the B cells and also thereby stimulating the virus present in the B cells. So this virus present in the B cell can activate the T killer cells and thereby activating the immune response and causing more tissue inflammation or tissue damage. Now let's move back to the eosinophilia, which I talked about. So the CD4 cells present in the lymph node are the T helper cells, and the T killer cells which are then activated with the T helper cells, which is CD8 cells. In this both, they are activated by interleukin 5. Now interleukin 5 is important because it is by interleukin 5 then eosinophilia can proliferate or increase in the number. This reaction happens in the bone marrow. So in the bone marrow there is the circulating granulocytes which are eosinophils. So when this T helper cells, which are CD4 cells, and T killer cells, CD8 cells, when they are activated by interleukin 5, which again I would like to repeat, which are responsible for the activation, proliferation of eosinophil. Due to this hypersensitivity, the interleukin 5 causes eosinophilia, or the circulating granulocytes increase in the number. When these granulocytes increase in the number cause eosinophilia, the eosinophilia affects various organs. It releases granules and damages various parts or different organs in the body. Let's go one by one. It can cause, let's say in liver, it can there are hepatocytes, so it will cause hepatitis. In heart, there's cardiomyocyte. It can cause myocarditis. In lungs, or it can cause interstitial pneumonitis. In the kidney, it can cause interstitial nephritis. In the skin, it can cause rash, which is morbilliform rash, and also it can affect various different systems due to release of granules by the increased number of eosinophils, which is called eosinophilia. So the diagnosis, how do you diagnose the patient with Rett syndrome? So basically, again, you have to go back to the symptoms or the clinical presentation of the patient. There's something known as a Reggie-Scar score. So basically, in this, if there are some criteria, like there's a criteria for diagnosing DRESS syndrome, which is Naregi scar. So in this we have, let's say, a fever of more than 38.5 degrees Celsius, enlarged lymph nodes more than 2 size or more than 1 centimeter, atypical lymphocytes, eosinophilia, which is more than 20% or more than 1500, or between 10 to 20%, like 700 to 1499. Skin rash, the extent of it, like more than 50%. At least 2 edemas, infiltration, purpura, scaling. Biopsy suggesting DRESS. Internal organs involvement, like one of the organs involved, 2 or more, if there is a resolution in 15 days. Evaluation of all other potential causes such as anti-nuclear antibodies. We can do blood culture, serology for human herpes virus 6, chlamydia, mycoplasma. If any of these tests are positive and are more than 3, it is confirmed that more than 3 or 4, it is confirmed that it is DRESS syndrome. So remember, all the in the Regi scar score diagnostic criteria, we give points for each of these things. We give each of these 1 point. If none of, and there are more than 3 or 4, then it's definitely DRESS syndrome, and then you can move further with the other tests to confirm it. And let's talk about the treatment of DRESS syndrome. So basically, in the treatment, is like, firstly, you should immediately discontinue the offending drug. It's the first critical step in treating this disorder. So the treatment basically is giving intravenous glucocorticosteroids, or you can give oral glucocorticosteroids to reduce the inflammation, to reduce the increased number of eosinophils, the increased number of T lymphocytes. And also you can give immunoglobulins intravenously to the patient where the extent of damage is more in the organs. So that's it for today. Remember, this is just an overview or a gist of what is a DRESS syndrome. In detail, we'll talk about this syndrome in the further podcast somewhere down the line. Thank you so much.